your very kind words. And thank you, Dr. Ashutosh, for giving me an opportunity. I'm going to talk for next 20 minutes about the uses of DAPA in CKD, non-diabetic CKD, and non-diabetic heart failure. So what I'm going to do in next 20 minutes, just let me share my slide. Is it visible?
Yes.
So DAPA in non-diabetic heart failure and CKD. First and foremost, very important thing that the way we are seeing a lot of patients with CKD and a lot of patients with heart failure, these both the conditions are actually speaking increasing all over the world, in India also. The way diabetes is increasing, we are seeing a lot of patients with diabetic heart failure and diabetic CKD. At the same time, we also see a lot of patients with non-diabetic heart failure and non-diabetic CKD also. Sometimes, even in a diabetic patients, there is a possibility of non-diabetic CKD too. That's for heart failure that you cannot say, because if somebody is having a diabetes, we always correlate that it is either a patient is having heart failure primarily maybe because of coronary artery disease, or diabetes is a superimposed disease with that. With these few words, once again, thanks to Ashutosh for giving me an opportunity. Let me first talk about the DAPA heart failure. I think this is one of the most important clinical trials which had happened after EMPA-REG outcome trial. We all know that since 2015, when EMPA-REG outcome trial had come, completely there was a paradigm shift as far as management of diabetes is concerned. And we started using as a first choice of therapy all SGLT2. And then there are many more cardiovascular outcome trial of KENA and DAPA had come. But this particular trial, which had come particularly with the patients of heart failure, and these patients were 4,744 patients. These were patients already having LVF of less than 40. But the main important thing, these patients, whether they are diabetic or non-diabetic, they should have ejection fraction of less than 40. And this was the trial. One arm was given Dapagliflozin and other arm was given placebo with complete standard of care. So the standard of care was very high in these patients. Everything was given, whatever was available at that point of time for the care of these patients. And what was the primary endpoint? Time to first occurrence of any of the components of the composite CV, either death, hospitalization for heart failure, or urgent heart failure visit. While there are secondary endpoints like time to first occurrence of either components of the composite CV, death or hospitalization for heart failure, total number of hospitalization for heart failure and CV death, change from baseline measured at 8 months in total symptom score of KCCQ, or time to first occurrence of any components of the composite more than 50% of sustained decline in EGFR reaching end-stage renal disease or renal death, or time to death from any cause. So these were many secondary endpoints was there, but primary endpoint was very, very clear. The patient with ejection fraction of less than 40, time to first occurrence of any of the components of the composite, CV death or hospitalization for heart failure or urgent heart failure visit. Now the baseline characteristic, the mean age of these patients was 60. I'm not going in the detail, but one thing is very clear, it is all over the world. Even in Asia Pacific, we were having almost 23% of the patients. And the 42% of the patients were having diabetes history, 58% of the patients were having non-diabetic also. The key baseline, other than that, almost all patients were having NYHA class 2, 3, or 4. So all these patients with mean ejection fraction of 31, with median NT-proBNP in both the arms was more than 1400. So this is again very important. So all these patients with a median NT-proBNP was more than 14 also. The medical history, if you see, as I told you, the diabetes, obesity, hypertension, history of myocardial infarction. They were the patient with PCI, CABG, stroke. So all those risk factor, diabetes, obesity, and hypertension, and some of the patients were already on coronary artery disease. As I told you, these patients were already on heart failure treatment, which include diuretic, ACE inhibitor, or ARB, either is or ARB. Even ARNI also was there in 11% of the patients. Beta blocker was given in 96% patient. Mineralocorticoid receptor agonist was in 71%. Even digitalis was there in 19%. Ivabradine was in 5%. CRT and even ICD, which is the therapy, the newermost therapy, it was also there. So, I mean, the baseline treatment for these patients was the standard of care for these patients was very, very high, even those who were in placebo or those who were in DAPA arm. The patient, as I told you already, that in the both the arms, it was equivalent, DAPA as well as in placebo arm. The distribution of patient, as I told you, there are 18% of the patients who were completely non-diabetic. But as I told you, even there was a pre-diabetes was 1/3 of the patients. They were actually not having history of diabetes, but when they were recruited, when their A1C was done, when their fasting plasma glucose was done, they were found to have pre-diabetic status also. So actually, 18% of them were purely non-diabetic, and 37% of the patients were pre-diabetic also. Now, this is very interesting, the primary endpoint, the CV day, the hospitalization for heart failure or urgent heart failure visit. You can see from the day one, the benefit was there in DAPA arm. So as soon as it was started, even in the first week itself, there was a benefit. And NNT was only 21. The HR is 0.74 with the median of 0.74 between 0.65 to 0.85. The p-value was very, very significant. And number to treat is only 21. So if you are treating a 21 patient, there is a definite benefit. The primary endpoint benefit either of CV death, hospitalization for heart failure, or urgent heart failure visit. So you can understand the benefit was really very, very significant. The 26% relative risk reduction of hospitalization for heart failure, urgent heart failure visit, or CV death. The worsening heart failure events, if you consider, it's very significant again with a 30% relative risk reduction with the patients who have worsening heart failure events. If you see the cardiovascular death, that benefit was there after 3 months. So you can see here the hospitalization for heart failure benefit was the day one. But if you see 18% relative risk reduction in 24 months, and that benefit was there as far as cardiovascular death is concerned in the patients who have LVEF of less than 40, whether they were diabetic or non-diabetic patients also. So all primary endpoints, whether they were diabetic or non-diabetic, benefit was there. HR, as I told you, 95% confidence interval. Baseline EGFR, even those patients who have higher EGFR or lesser than EGFR, those patients who were on mineralocorticoid receptor agonist at baseline, or they were not, it was not making any difference. The point is, those patients who are having NYHA class 2, the benefit was more in compared to the class 3 or 4. So probably a patient with a severe heart failure, there was less benefit, but in compared to the patients who are having early course of the heart failure, the benefit was more. The patients who have higher ejection, better ejection fraction, higher NT-proBNP, or those patients with atrial fibrillation were found to have less benefit. So the higher NT-proBNP, lesser ejection fraction, naturally they will have less benefit. But the patients who are relatively with the NYHA class 2 with NT-proBNP was less and atrial fibrillation was not there, they were benefited highest. The primary endpoint, even in the patients who are elderly or even those who are lesser than 65, female and male sex both, in all race, but in the Asian and Black, the benefit was more. The same way, the patients who are in Asia, North America, and South America, benefit was more in compared to the European population. Those patients who are having already history of hospitalization for heart failure, the benefit was more. The patients who are non-ischemic, it means we don't know what is the reason for them for heart failure. Ischemia was not there. It was not the CAD, the benefit was more. Even the patients whose BMI is more than 30, the benefit was more in those patients also. Even with a pre-specified group, as I already told you, the patients whether type 2 diabetes was there at baseline or not, and post-hoc analysis in subgroup patients, even with the patients who are already on ARNI, they were also got the benefit. So it means the patients on a heart failure, even those who are on ARNI, still they will get a continuous benefit of this molecule, and they have a synergistic benefit for the patient with LV ejection fraction of less than 40. DAPA consistently reduced the rate of CV death, worsening heart failure events, regardless of diabetes status and A1C, and the CV death and worsening heart failure was better in the patient with DAPA arm. The secondary endpoint, the CV death and hospitalization for heart failure, again, there was a significant improvement with 25% relative risk reduction. The same way, total heart failure, hospitalization, and CV death, again, 25% relative risk reduction. And even the cardiomyopathy questionnaire, that's very important as far as quality of life is improvement, that was also found to be better with the patients who were on DAPA. Also, the all-cause death, which is the secondary endpoint, again, that benefit was also there in the DAPA arm, which was 17% relative risk reduction of all-cause death. Now, the safety point, if you know that we are worried of some of the issues with diabetic ketoacidosis, fractures, renal adverse events, volume depletion, and some of the infection which we are worried, but it is almost comparable with the placebo. Even diabetic ketoacidosis only 0.1, which was a major issue. The amputations, no significance. Fracture, both the arms same. Renal adverse events, even it was less in DAPA, and volume depletion was slightly higher with the patients who were having any serious adverse events was less in the arm of DAPA in compared to that. So no difference in safety outcome in a patient with diabetic status, whether they were diabetes or non-diabetes. As far as safety concerned, as far as adverse events are concerned, in both the arms it was same, and both the arms, those patients, whether they were diabetic or non-diabetic, there was no difference. So the DAPA heart failure summary is, it is the first heart failure outcome trial. So dedicated patient with heart failure. It was not with established CVD, only with established heart failure, with SGLT2 inhibitor investigating the treatment of heart failure in adults with reduced ejection fraction on top of standard of care. And that is very important. The top of standard care, which includes ACE, ARB, beta blocker, MRA, and RNA in patient with or without diabetes. DAPA provides a statistically significant and clinically meaningful reduction in the risk of worsening heart failure events and cardiovascular death when compared to placebo, as well as improvement in heart failure symptom when added to standard therapy. The safety finding of DAPA heart failure were consistent with well-established safety profile of DAPA, and the rate of discontinuation was low. The second part of the study is DAPA CKD, and that's again a separate study which was done in the patient with a chronic kidney failure. What was the rationale behind giving the dedicated trial of DAPA CKD? And again, the patients were non-diabetic also, because the Credence trial was a dedicated renal trial with CANA, but these patients were diabetes kidney disease only. While CKD, as we know, it's a global healthcare problem. It's a significant contributor of CV morbidity and mortality. Until recently, the only treatment was either ACE or ARB. Declared trial demonstrated the benefit of DAPA in a heart failure and renal outcome. Rather, all CVOT trials had demonstrated that benefit, and that demonstration was there again in DAPA heart failure trial, because that was a secondary endpoint. But DAPA CKD trial is a dedicated trial of Dapagliflozin on a renal and CV outcomes and a mortality in patients with CKD. But again, whether they were diabetic patients or a non-diabetic patient was not considered. So that is what DAPA CKD trial. In DAPA CKD trial, again, key inclusion was these patients were with or without diabetes, and their eGFR is between 25 to 75. The exclusion was definitely type 1 was removed, polycystic kidney disease was removed, and those patients who were on immunosuppression, they were not included in the trial. The primary endpoint was very clear, the composite of sustained more than 50% eGFR decline, end-stage kidney disease, renal or CV death, with secondary outcome was again for the composite of sustained more than 50% eGFR decline, ESKD or renal death, composite of CV death or hospitalization for heart failure, and all-cause mortality. The countries which was participating, again very important, Asia was part of it, and India we were having 201 patients. The baseline characteristic for these patients, again Asian was almost 35% of the patients, and 68% of the patients were not having CKD because of diabetic. I mean 67% of the patients were having both the arms were 68%, 32% of the patients were not having diabetes in this Dapagliflozin trial. Again, in a medical history, the same, they were obese, hypertension, any CV disease, heart failure, myocardial infarction, and stroke. So obesity and hypertension was more common in the patient with overall population. 95% of the patients were having the hypertension, while the diabetes was there in 68% of the patients. These patients were again on RAS blockade. They were on direct renin inhibitor also, very few. Diuretic, ARNI, MRA, beta blocker, calcium channel blocker, and even statin was there with all these patients. The renal characteristic was again divided, as I told you, less than 75 to more than 25. Less than 30 ml was 14.5%, and maximum patient was between 45 to 59, that is 30% of the patient, and 30 to 44% was 44% of the patients was between this arm. So I mean, the patient with a stage 2 or stage 3 kidney failure, we were having highest number of the patient. Now, this is again, the primary composite outcome was sustained more than 50% EGFR decline, ESKD, renal or CV death. You can see here, there was a 39% relative risk reduction. And again, this benefit you could see from 4th month only in 32-month trial. NNT is again 19. So in 19 patient, if we are treating for renal benefit, patient with DAPA, whether they are diabetic or non-diabetic, with eGFR of less than 75, you will find within 3 months the benefit, and that continued the benefit, and relative risk reduction was 39% with a significant p-value. And within 19 patients, if you are treating, you are going to decrease one, either the eGFR decline is sustained, that benefit is there, or renal or CV death is also benefit. The DAPA is doing better for the all primary composite outcome. Even the patients who are having secondary components also, as far as ESKD is concerned, renal death is concerned, or CV death is concerned, all of them are having, the patients who are on DAPA, they got the benefit for that. Those patients who were having diabetes or non-diabetic, even non-diabetic CKD was better as far as individual difference is concerned. They responded more. The patients with higher EGFR were having better because their further decline was reduced significantly. Urine albumin creatinine ratio is less than 1,000 was better in compared to the patients who are more than 1,000, but both were having the benefit for that. The patient with less than 65, more than 65, male, female, any race, again, as I told you, the Asian and blacks were more benefited in compared to the white and others. The geographical distribution in Asia and systolic blood pressure, those patients who are having more than 130 were having less benefit in compared to the patients who are less than 130 systolic blood pressure. The secondary composite outcome was sustained more than 50% decline in EGFR decline with ESKD and renal death. Again, there is a 44% relative risk reduction with in placebo arm, there was 243 events in compared to the DAPA, it was 142 with a significant p-value. Again, benefit you can see within 4 months it started, and both the curves had started getting separated even at the time of within 4 months also. The exploratory composite outcome, which is chronic dialysis, kidney transplantation, or a renal death, again 34% relative risk reduction with a significant p-value. But this graph was started separating after 8 months. I mean, you can see the patient with at the time of initiation within 3 months, 4 months, and 8 months, the benefit was different, and this benefit you could see after the 8 months of starting the therapy. But the CV death and hospitalization for heart failure, as I told you in DAPA heart failure also, the similar data was there from the day one, and that data was the patients who have eGFR of less than 75, the patient with CKD, whether they were diabetic or non-diabetic, 29% relative risk reduction in patients who are as far as CV death and hospitalization for heart failure in DAPA CKD trial. The secondary outcome, all-cause mortality, again, there was 31% relative risk reduction. And this statistically significance achieved for primary and all secondary outcome data, including all-cause mortality and primary outcome data. I already told you there was significantly DAPA was doing better in patient with DAPA CKD. Now, again, the issue of safety, discontinuation of the drug, almost same, rather there was less in DAPA arm. Discontinuation due to adverse event, again, it was less in DAPA arm in compared to placebo. Any serious adverse event, it was less in DAPA in compared to placebo. And now again, we talk about the lower limb amputation, and diabetic ketoacidosis, fracture, renal-related adverse events, major hypoglycemia, volume depletion, serious adverse events, they all were less in the patient with Dapagliflozin arm. Dapagliflozin arm subgroup analysis in patient with type 2 diabetes patients, the demographic and baseline characteristic of diabetes status, even in any, I mean the age of the patient, the female sex, all these, they were all got the benefit, those patients who are diabetic CKD and even they are without diabetes. So there was no difference as far as DAPA CKD trial is concerned, whether the patients who are type 2 diabetes and they were put on dapagliflozin, or those who were put without diabetes also put in the diabetic and non-diabetic patient, the benefit in both the arms were same. With the medical history, as I told you, the hypertension was almost more than 90% and more patients with the obesity also. And the primary and secondary outcome in the patient with diabetic status, overall, the patients without type 2 diabetes were having more benefit, primary outcome, renal specific outcome, CV death and hospitalization for heart failure in all three groups, it is same, and all cause mortality was also more benefited in the patients who are non-diabetic in compared to the diabetic arm. The primary outcome, as I told you already, with the in diabetic status, the benefit was more in the patient with diabetes, even patient without diabetes, this benefit was almost comparable. The secondary renal outcome, if you just compare patient with type 2 diabetes and patient without type 2 diabetes, again, it is same as far as safety analysis is concerned. Diabetes status has not changed any safety benefit. So the benefit was there in both the arms, whether they were in placebo, whether they were in DAPA. There was no serious adverse events, and both the arms were having almost similar adverse events, which was there. Either they were diabetic or on placebo, whether they were non-diabetic with placebo, it was no significant difference as far as adverse events are concerned. Discontinuation and serious adverse events of UTI and genital infection by diabetes status. And we know that it's slightly higher in the patients who are having with diabetes in compared to without diabetes. And that means we know it's slightly more in the patients who have sugar level, because sugar gets more getting excreted, and that could be the reason that in slightly it was higher in the patient vulvovaginal mycotic infection, urogenital infection, which was slightly higher in compared to the placebo. To summarize DAPA CKD, in this pre-specified analysis, DAPA reduces the risk of renal events, CV events, and all-cause mortality regardless of type 2 diabetes status. This is very important. So in non-diabetic as well as diabetic, there was a benefit. DAPA was well tolerated as far as safety profile is concerned. It is consistent in patients with or without type 2 diabetes. Serious adverse events of genital and urinary tract infections were very low. Still, it is slightly high in the patient with type 2 diabetes. Genital and urinary tract infection, serious adverse events were more frequent with DAPA than placebo in type 2 diabetic patients. But it was comparable without type 2, and there were very few discontinuation due to adverse events of UTI or genital infection. To summary, DAPA CKD is a first dedicated renal outcome trial. We were having credence, but that was in diabetic patients. This is even diabetic and non-diabetic. There was 39% relative risk reduction in primary composite outcome, and we know that secondary benefit was there. Consistent treatment effect in patient with CKD across major subgroup, including patient with or without type 2 diabetes, a baseline EGFR and urine albumin created category. DAPA was well tolerated for treatment of CKD, and data confirm the known safety profile. DAPA CKD builds upon the evidence for DAPA in prevention of hospitalization for heart failure and worsening of renal disease in DECLARE, and that in reduction in risk of worsening heart failure and CV death that was there in DAPA heart failure. So DAPA CKD further, it builds upon the evidence, the same evidence which we had seen in DECLARE, which was much higher in DAPA heart failure, and DAPA CKD talks about the same benefit, which was prevention of hospitalization for heart failure and worsening of renal disease. DAPA CKD expands the cardiorenal benefit of DAPA to the patient with CKD. So we have a DECLARE trial, we have DAPA heart failure, we have DAPA CKD. The patient's population you can see here with a multiple risk factor or with established cardiovascular disease in DECLARE. In DAPA heart failure, dedicated patient with a EGFR of more than 30, but they have ejection fraction of less than 40. DAPA CKD trial where EGFR is a primary more than 25 for the patients. They were with or without diabetes in DAPA heart failure and DAPA CKD. Mean EGFR was lesser in the patient with CKD. DAPA heart failure also it was less. In declared it was normal. Primary endpoint, as I talked to you about CV death and hospitalization for heart failure. In a heart failure trial, it was hospitalization for heart failure and urgent hospitalization, heart failure visit. While in deep DAPA CKD, it was more than 50 EGFR decline, ESKD or renal or CV death. And the benefit was there in all these three clinical trials. And this had strengthened the evidence that dapagliflozin and across the, all SGLT2 benefit not only the patients who have established cardiovascular disease in patients of diabetes, but even without diabetes, those patients who have renal dysfunction and those patients who have LV dysfunction, the benefit of SGLT2 inhibitor is very high in the patients of non-diabetic heart failure and non-diabetic CKD patients. With this, I once again thanks Dr. Ashutosh and giving me an opportunity for this fantastic talk. Thank you.